Well, I would like to welcome everybody to this IDF webinar. This is the webinar for the IDF Guide for Diabetes Epidemiology Studies. I'm Jonathan Shaw from the Baker Heart and Diabetes Institute in Melbourne, Australia, and it's been my privilege to be part of the process that has led to the development of this guide over the last several months. And we have this evening a truly international cast of people to explain and highlight the value and importance of this guide. You, I hope, have seen in the chat function some general welcoming remarks and housekeeping information, particularly noting the questions feature, because we will have a section at the end where we will try to answer as many questions as possible that people pose. I don't know that we will be able to get through all of them, but hopefully a good range of them. So we're going to cover many aspects of this. It is a fairly superficial view of the guide, and I would strongly recommend that people read the guide, and there will be further information coming out about it. I'll start by just briefly introducing each of the speakers tonight so that I don't have to get in the way as we switch over from speaker to speaker. And I'll start with Suvi Karuranga. Suvi is a public health nurse with a master's in public health from Lund University, who's been with the IDF for several years as the epidemiology manager. We also have Dr. Jackie Kassouf Maalouf. She is the founder and president of DiaLeb, the National Diabetes Organization and a leading diabetes organization in Lebanon, which she founded, and she's passionate about promoting the importance of looking after people with diabetes. Professor Ayesha Motala from South Africa is a specialist physician in diabetes, and she's clinical head in the Department of Diabetes and Endocrinology at the University of KwaZulu-Natal in Durban in South Africa, and has been a long-term member of the Diabetes Atlas Committee. Dr. Douglas Villarreal is an endocrinologist based in Santa Cruz, Bolivia. He's chair of the IDF Central and South American region and works as the director of the Susan Hu Medical Center. We are also, I'm delighted to say, have Professor Pablo Ashner, who has really driven this whole process. He's Associate Professor of Endocrinology at the Javeriana University School of Medicine and Senior Research Advisor at San Ignacio University Hospital and Scientific Director of the Colombian Diabetes Association. Dr. Graham Ogle from Sydney in Australia is a pediatric endocrinologist. He works for Diabetes New South Wales as a general manager for the Life for a Child program, and has had many years of involvement in epidemiological studies of diabetes in children, and also improving services and access in developing countries. Sarah Wild is a professor in Edinburgh. She did her medical training in London and in Cambridge, and has worked extensively in diabetes registries, particularly in Scotland. And so that is the cast that we have for tonight, and without any further ado, I'm going to hand over to Suvi Karuranga, who will provide some welcoming remarks.
Good morning, good afternoon, and good evening, everybody. Thank you, Professor Shaw, for the introduction, and thank you to all for registering and attending this webinar. It is a privilege on behalf of IDF to welcome you to the launch of the IDF Guide for Diabetes Epidemiology Studies. Next slide, please. The IDF Guide for Diabetes Epidemiology Studies has been written by a scientific committee of diabetes epidemiology experts across the world, chaired by Professor Pablo Ashner. IDF would like to express its thanks to Sanofi for supporting this project. Next slide, please. The IDF Guide for Diabetes Epidemiology Studies is inspired by the IDF Diabetes Atlas, which has been an authoritative resource on the global impact of diabetes since it was first published in 2000. The 10th edition will be launched in November later this year. The data portal and resources are downloadable at diabetesatlas.org. Next slide, please. The latest estimates from the 9th edition of IDF Diabetes Atlas suggest 463 million people are living with diabetes worldwide, and the numbers are expected to rise to 700 million by 2045. This means IDF estimates that 1 in 11 adults is currently living with diabetes. Next slide, please. The burden of diabetes may overwhelm many healthcare systems, particularly those in low and middle-income countries. Addressing the diabetes burden will require concerted effort at national, regional, and global levels. To advocate for action, the global diabetes community needs reliable data on the distribution of the condition, both prevalence and incidence, and the risk factors that are driving the trend. Next slide, please. The number of countries providing data on diabetes prevalence of sufficient quality in IDF Diabetes Atlas has increased. In 10 years, we have gone from 91 countries in 2009 to 138 countries in 2019. This is extremely encouraging. Unfortunately, significant gaps remain. IDF estimates that a third of all countries do not have good data. IDF wants to address this shortcoming. The need for more data motivated the IDF Diabetes Atlas Committee under its then chair, Professor Rhys-Williams, to develop this guide. The aim is to help researchers design, conduct, and publish high-quality studies that generate robust data. The goal is to deliver the evidence to improve care and strengthen healthcare systems. The target audience for this guide includes clinicians who want to generate local diabetes epidemiology data and epidemiologists who want to standardize diabetes-related criteria. International Diabetes Federation hopes that the guide will help inspire and support action to address the burden of diabetes through research. IDF is inviting everyone to promote the guide and support the efforts to complete the global picture of diabetes. Next slide, please. Thank you for listening.
Thank you, Suvi. Thank you for that excellent background to this. And so before we get into what we actually have in the guide, we have three speakers presenting from a local or regional perspective what it means to know about the diabetes numbers and the diabetes prevalence in their country or their region. And as I said before, I'm not going to introduce everybody because we've already done that. So first of all, we have from Bolivia, Dr. Douglas Villarroel.
Hi, I am Douglas Villarroel, born in Santa Cruz, Bolivia, chair of the SACA region, IDF SACA region. Diabetes mellitus presents a high economic burden to both individuals and society, not only due to healthcare costs, but also to indirect costs caused by loss of productivity and premature mortality. People diagnosed with diabetes are increasing in numbers every year and experiencing medical expenditure 2 to 4 times higher than those of their non-diabetic counterparts. Not having up-to-date epidemiological research on diabetes in Bolivia is a big health concern because the disease itself has proven to be the catalyst for other health problems, and we need to know the numbers more. Diabetes is a health problem in Bolivia with serious deficiencies in its prevention, diagnosis, and management. However, the impact of public health is not reflected in the numbers of articles published. The medical scientific production in Bolivia is lower than the countries of the region. This low scientific productions in Bolivia is related to the training of health professionals, which is more focused on clinic than on research. Another important limitation lies in the lack of budget for diabetes research in Bolivia. No level of government or private institution allocates money for these purposes. The IDF Guide for Diabetes Epidemiological Studies will probably help Bolivian researchers conduct better quality diabetes studies and, this way, to be able to have appropriate healthcare interventions. Fueled by the rise in the prevalence of obesity and unhealthy lifestyles in Bolivians, Bolivia is now confronting a high and rising disease burden related to diabetes. The IDF Guide for Diabetes Epidemiological Studies will help Bolivia to know the estimates about the incidence and prevalence of people with diabetes now and the expected rise in the future. Thank you for inviting me to the IDF Guide for Diabetes Epidemiology Studies virtual launch ceremony. And congratulations to all involved in such important and necessary guide.
Douglas, thank you very much for that perspective from Bolivia. We now move to Lebanon, to Dr. Jackie Kassouf Maalouf, to hear a perspective from that region.
Thank you very much, Jonathan. I'm very happy to be here today. I am Jackie Maalouf, founder and president of DiaLeb, the National Diabetes Organization in Lebanon. It is really a pleasure to be speaking today at the launch of this very important diabetes epidemiology study, and would like to go to the next slide, please. Next, please. Thank you. I'll start by speaking about the challenges and data gaps and processes for data collection that present definitely many challenges, starting with the lack of up-to-date national registry for patients. I'm not saying we don't have them. We do. We have very interesting studies. They are not just not representative of the entire population. The lack of representation of the non-Lebanese on Lebanese soil, that by itself is a whole different issue. Timely and cumbersome processes to get data validated and endorsed by our Ministry of Public Health, the lack of structured reporting process by doctor diagnosis on NCDs or non-communicable diseases, and ultimately ongoing political and economic crisis present difficulty in data collection efforts and obtaining project financing. Next, please. I'm just showing here an example that we do have very interesting studies by prestigious universities, prestigious NGOs, and this is from 2020. It is just focused on type 1 diabetes, so it is not really representative of the whole nation. Next, please. The key facts, some of them we all know very well. I would like to highlight that diabetes is the fastest growing disease globally. The MENA region is the second region after Africa with highest number of deaths caused by diabetes complications. The need for updated and accurate database showcasing diabetes prevalence is of utmost importance. And let me say here that epidemiology is not just the study of health in a population, but also involves applying this knowledge gained and studying the impact in this population. It is therefore essential to support evidence-based policymaking and scientifically grounded programs. Next, to my most important slide, which are, I'm going to highlight here the benefits that I see and the value add of this guide to research. First, it supports IDF member association by offering research models and innovative methods of data collection and analysis. It enables sharing of research, maybe not at this point, but we hope later we will have best practices in diabetes epidemiology for best approaches and outcomes. To practice and national health policies, it translates into better management of the patients, It creates an action plan as part of a national public health and NCD policies, and it supports the development of targeted policies based on updated prevalence and incidence numbers, and accurate ones, of course. And to the last slide, if you please. I would like to finish by addressing every single one of you. If you think diabetes is not your problem, look around you. With this picture from our DiaLeb 2018 campaign, when the theme was protect your family, and I think it should be always an ongoing theme. Thank you very much for inviting me to speak today, and congratulations to all the writers, to all the people who are involved in bringing to us this very important guide. Thank you.
Jackie, thank you very much for that impassioned presentation from the situation in Lebanon and the region. And now we move to the third of these region perspectives. This is from Professor Ayesha Matala from South Africa.
Thank you, Jonathan, and greetings from sunny South Africa. We all know that diabetes is a global and epidemic problem, and sub-Saharan Africa has not been spared. From the latest estimates, the greatest increase in the number of adults with diabetes is projected to be in the Africa region, from 19 million in 2019 to 47 million in 2045. And in 2019, diabetes was increasing in every country on the continent. It had the highest proportion, that's 60% of undiagnosed diabetes in the world. And the healthcare expenditure on diabetes from the continent at 6.5 million was the second lowest for the world. Now, for generations, the healthcare agenda in Africa has been dominated by infectious diseases and poverty, with little attention being paid to non-communicable diseases. And therefore, a major turning point was the United Nations resolution on the prevention and control of NCDs, and the commitment by African governments to the Sustainable Development Goals, in which one of the targets was to reduce mortality from NCDs by 30% by 2030, and the adoption of the WHO action plan for NCDs. Now, Africa is the second largest continent with a population of just over 1 billion, living in over 50 countries, and it has one of the fastest rates of urbanization in the world, but with countries at different stages of the epidemiological transition. Currently, sub-Saharan Africa has the highest proportion, that's over 70%, of the United Nations defined least developed countries, which face the multiple burden of resource depletion, the onslaught of communicable diseases, and now non-communicable diseases such as diabetes, which until the 1980s was considered very rare, unknown, or absent from the very few studies that were available. Now, over the last 3 decades, the data on the epidemiology of diabetes from the region has increased, and depending on the sampling methods and the criteria used, the prevalence is variable, but it is not rare. And in many countries, moderate to high rates are found. The problems with the available evidence is that comparison between the studies is extremely difficult because of the widely variable study methods and diagnostic criteria that have been used. And in 2017, the Lancet Commission declared for sub-Saharan Africa that the true burden of diabetes and its complications for sub-Saharan Africa is actually unknown. And there's a lack of high quality data. And for the healthcare systems in sub-Saharan Africa to be able to achieve the targets of the Sustainable Development Goals, one needs collaborative attempts to have uniform epidemiology data from the region. So there's no better a time than now to have these guidelines that are being launched by IDF. And on that note, I will stop. Thanks.
Ayesha, thank you very much for that. So that completes the regional views and the sort of the general background to the genesis of this guide. And so our next speaker is probably the most important that we're going to hear tonight is Professor Pablo Ashna from Colombia, who has chaired and spearheaded and cajoled and encouraged all the other people working in this guide to produce this high quality document. So Pablo, over to you to give us an outline of the guide.
Thank you, Jonathan. Can I have the next slide, please? Well, as Suvi already mentioned, the idea of this guide came when we discussed it with Professor Rhys Williams, who at that time was the chair of the IDF Atlas Committee. We saw the need for guidance to generate high-quality diabetes epidemiology data using standardized criteria. This kind of data, as has been already mentioned, Ayesha just mentioned it referring to Africa. This kind of data was missing in a considerable number of countries and had to be generated by the Atlas using extrapolation from other countries, which created some confusion. But the main purpose of this guide went beyond the Atlas, and we thought that it should help researchers to design, conduct, and analyze and publish high-quality diabetes epidemiological studies. And the target was not only clinicians who were new in this field of epidemiology and would find here a guide to do studies, but also for epidemiologists who would want to standardize their diabetes studies using diabetes-related criteria. Next. And so here we can see the table of contents, so to speak, the menu of what you can find in this guide. It can be used by choosing the chapter you need for your particular study, or you can just read it as a very enjoyable textbook. Next, please. Okay, so we have a chapter on principles of conducting prevalence studies, which is the cornerstone, the marker, the main metric of diabetes epidemiology, and it's quite complete. We address, for example, the issues related to sample size, which are very important in this kind of studies, and we also discuss something which still is a matter of controversy, the different tests for diabetes and how can they be used in prevalence studies. We also added another chapter on how to organize and conduct a survey. This is very practical. It even has an example of a survey protocol as an appendix, and goes through all the items that you need to organize a survey. Next, please. This chapter on data handling and statistical analysis is very important and has been addressed in a very friendly way, so that being a very complicated issue, the statistical analysis, it becomes quite practical and simple thanks to our co-authors. Next, please. The incidence chapter, I just forgot to mention it, addresses another very important metric, but which has been more difficult to produce, particularly with type 2 diabetes, since the incidence is elusive due to the natural history of the disease. So now, yes, next. The mortality, survival, and life expectancy are very important and are also addressed and how to measure them. Hopefully, this kind of data will appear more and more in our epidemiology reports and have become a very important part of the atlas. There's a chapter on diabetes registries, which will be shown through the lecture that we will have next from Professor Wild. So I'm not going to extend on that. Next. And then we have these two issues on special populations. One of them is on pregnancy, which has some challenges and how to diagnose it and what kind of outcomes we should use for the study of pregnancy. And then children and adolescents, which is a very important chapter and is going to be addressed by Dr. Ogle also during this webinar. Next. And finally, we thought it was very important to have some guidance on how to publish our results, because unfortunately, many of the results from epidemiology studies are not used because they are not published. So everything that's produced should be published, and here we present a practical guide on how to do that in a way that it will be accepted by peer-reviewed journals and will be known by the international community. And the advocacy chapter, we thought it was also important because these data should be used to raise awareness on diabetes and its complication and engage stakeholders in prevention and management, and ultimately to establish national diabetes plans or programs and appropriate to local contexts. And for that, we need a lot of epidemiology, local epidemiology data. So next. By this, I hope I have given you a very summarized overview of the contents of the atlas, of the, IDF guide. And I hope you will be able to go through it, to browse, to enjoy it, and use it for future epidemiological studies. Thank you very much.
Pablo, thank you very much for that great overview, and I hope that people get a sense now of what is covered in the guide. Please send in any questions that you have using the question function. Send in those questions. We're going to only highlight a couple of the sections, but if you have questions about any aspects of diabetes epidemiology, particularly those covered by the guide, I hope that we have somebody on the panel who can answer that, all the way from the technical through to the advocacy and what it means for people working at the coalface and people, most importantly, with diabetes. So now let's start to look at a couple of these chapters. And the first is going to be presented by Professor Sarah Wild. And Sarah is going to give us an overview of the issues around diabetes registers.
Thank you very much, Jonathan, and I'm delighted to contribute to this webinar. So I'm fortunate enough to be based in Scotland, hence my warm gloves, where it's winter and cold and rainy here. So I'm was fortunate enough to move to Scotland when a diabetes register had already been well established. And so some of the logos on this slide indicate the people who've been involved with the diabetes register. And I'm going to move on to the next slide, please. So just as a bit of a background to define it, what a diabetes registry is, it's a systematic collection of data for a group of people to produce a register. And this might be, for example, a hospital clinic, or as we've managed to be able to do in Scotland, for the population of a whole country. Registers are really useful to be able to both support clinical care, but also to provide data at a population level to plan and evaluate quality of health services, and also to inform and evaluate policies for prevention of diabetes and its complications. Suvi showed the data for the IDF Atlas, and much of the data, or some of the data rather, from the IDF Atlas comes from population-based registers. And then, of course, registers can also be used to conduct clinically relevant audit and research. So I've started with the gain of having registers, but it's also important to mention some of the pain, the challenges for setting up and maintaining registers. I'll have the next slide, please, if I may. So I've used the Scottish register and some of its components to illustrate some of the complexities around setting up a register. As many of you will know, there are many aspects to diabetes care, both in primary care and in hospital settings, and with information from various other important clinical aspects that all need to be brought together. And that requires the technical aspects, the computerized aspects of it, but also important factors that are very setting or country specific in terms of data security, which I've listed there as data governance. And certainly I can speak from experience in Scotland that over the years, the rules around data security and data governance change. And so it's a constantly moving environment. One of the advantages, though, for having a good diabetes register, at least in countries where there's a good quality death register, for example, it's possible to link diabetes registers to death registers. And then that gives us information about, obviously, one of the key outcomes of health, which is death. But we might also be able to, in some settings, look at linkage to other registers, such as cancer registers. But that, I realise, is a pipe dream in many countries. The next slide, please. So to bring all of this together, I think I've provided some of the examples of the gain for having a register. So I'll just mention a bit more about the pain. We need multidisciplinary expertise and sufficient funding and real persistence to set up and maintain registers. So essentially, we need enthusiasts with a lot of patience and time. I think it's important to realise that setting up a register increases the workload initially before it reduces the workload. We have to be aware that there are changing rules for data governance and that population-based registers have limitations. I think one of the key challenges as well is to use register data effectively to improve outcomes for people with diabetes and to facilitate clinical care. So I look forward to further discussion about this. I thank the organisers for giving me the opportunity to speak, and I'll hand back to Jonathan. Thank you.
Sarah, thank you very much for that beautiful overview of the strengths and the challenges of registers. And now let's turn to the second specific focus that we have. And just a reminder to everybody that we just cherry-picked a couple. This isn't to limit what we can discuss in the Q&A section. And so in this section, Dr. Graham Ogle from Sydney in Australia is going to talk about issues relating to these epidemiological studies in children.
Thank you, Jonathan, and greetings from Sydney on a summer evening. I'm grateful to be invited to speak on this section. It's true that most diabetes is in adults and that type 2 is more common than type 1, but children are always special. They are more vulnerable and their bodies and psychosocial situations are ever changing. Diabetes 2 is often different in them. However, in diabetes studies, they tend to get forgotten or just thought of as little adults, which they aren't. There are over 1 million children and adolescents with type 1 and others with type 2 and other forms. They walk a tightrope every day between dangerous extremes of low or high blood glucose, and without good long-term blood glucose control, they will lose decades of life expectancy from complications. In lower income countries, they may not even survive until their teens and 20s. They may die at onset because their conditions misdiagnosed as gastroenteritis or malaria or a host of other diseases, or they commonly die soon after diagnosis due to lack of access to full care. In some countries, when Life for a Child started helping, there were hardly any people with type 1 diabetes older than 23 years. It's so important then for health planning and resource allocation, for teaching of healthcare professionals, for improving clinical care, and for advocacy efforts, that every country knows three numbers about diabetes in children. The first of these is the incidence, the rate of new cases in the population. This varies at least 60-fold around the world for reasons that we don't fully understand. The second is the prevalence, the rate of existing cases in the population. How many cases are there? And the third is mortality. How many are dying and why? And yet in the atlas, only 45% of the world's countries even have incidence data. And that's mostly from high-income countries, and often it isn't recent. And we know that incidence is increasing by 3 or 4% per year in most countries that have data. Even fewer countries than 45% have prevalence or mortality data. The IDF guide provides clear information about how to establish a registry and do an incidence study, and the special populations, children and adolescents section provides specific information on studies in young people. The key points for studies in young people are that studies are needed from every country. If your country does not have data or recent data, see if you can change that. Particularly, there are gaps in sub-Saharan Africa, South and Central America and the Caribbean, and also parts of Asia. Also, older information needs to be updated. With old studies from the 1990s, the incidence may have doubled or tripled since then. When designing the study, it's best to have 2 or more complementary and overlapping sources of data. But often in less resource countries, that's not possible. But very good information can still be obtained from just one source as long as the data is well collected and the limitations are stated clearly. Examples of this are published studies from Bolivia, Uzbekistan, Tanzania, and Rwanda that are or will be included in the atlas. It doesn't necessarily need to be a whole country study. It can be a province or a couple of provinces as long as the population is big enough and the study's done well. Maximizing case ascertainment is also critical. Every effort should be made to include all new cases. But if you think you have nearly all cases and can make a good argument for that, you can calculate a minimum incidence and publish it as that, which is valuable in its own right. It's also important to remember that not all diabetes in children is type 1, and careful thought needs to be given to teasing out the type of diabetes as best as possible given the local resources. Remember also that diabetes presenting in the first 9 months of life is often due to a single gene defect, which sometimes can be treated with sulfonylureas rather than insulin. Genetic testing is needed on these cases, and this can be done free through a service in the United Kingdom. It's important also to think where the cases are being missed, dying at onset, and education campaigns have been shown to be able to change this. And finally, help and advice are available from experts if you need it. Just ask. So if you have the opportunity, please think what you and your colleagues can do to get the first information from your country or update any older information. No child or youth should die of diabetes. Thank you.
Graham, thank you very much for that. And that brings us to the end of the presentations. And so for the last 15 minutes or so, we will address some questions that have come up. I don't think we're going to be able to address all of them, but perhaps if all of the presenters would turn their screens and their videos and their microphones back on, we'll start to work through some of these questions. And the first question that I've got here that we'll try to answer is going to be for Ayesha. It's about prediabetes, and this is a question about whether IDF is planning an epidemiology study on prediabetes across the world.
Well, I'm not equipped to answer that because I think that's more a question for Suvi, I'd say, or for Pablo, but I'm not aware that IDF is planning to undertake any studies, but rather to provide the support if anybody wants to conduct studies. Pablo?
Yes, in IDF Diabetes Atlas 10th edition to be launched later this year, we are going to have a section on prediabetes, and normally that covers the analysis of estimates for global and region and nationally. So we have a special interest group performing this analysis and data collection currently.
So I think
that
what I can say is that
to be discussed is whether we should continue using the term pre-diabetes, won't we?
Yes, well, I think that the important point is that whenever studies are undertaken to determine the burden of diabetes, pre-diabetes, or I would like to call intermediate states of hypoglycemia, will also of necessity be assessed. I can't see how only diabetes would be assessed.
Perhaps I mean, I think to answer the question directly, that IDF is not currently planning, and I haven't ever known it to be planning its own surveys. This guide is perhaps an attempt to support other people to do that. But there have been some questions about funding. So there was one which was asking if IDF has any plans to support conduct of epidemiology studies in lower income countries or lower and middle income countries, and other questions have been about where people can look for funding in resource poor countries. Douglas, maybe I might put some of that, just try and get your perspective on that, representing at least South and Central America, which has a number of resource limited countries. If people are trying to search for funding, what are the ways they can go about that?
Well, most of the studies have been funded by World Diabetes Foundation. When they get good projects, they fund those projects. And IDF in the past has did some funding on some associations to do prevalence and incidence and in diabetes. Currently, there are 3, but it's not that IDF does it. IDF doesn't have enough resources to support studies everywhere. It's very difficult to get funding to do research in countries like Bolivia, because we don't have a budget from any level of government to do this. And privately, not even the pharmaceutical companies are looking at countries like Bolivia because they are so small, they don't sell much, and they are not in the market either. So they don't have interest in doing research. So, but I definitely think that this guide will help many to motivate themselves and do research and try to get funds from any means, because this is a very important guide for so many health professionals that do not know how to do it, how to do research.
Graham, maybe I could ask you about this. You've done a number of studies in some pretty resource limited countries. What suggestions can you make to people for looking for funding in such limited resource limited settings?
Well, I think for STEP studies for type 2, then the WHO can be very useful. And we did a study in Papua New Guinea funded by the WHO. I think for children, often not so much resources, and some resources are needed, but not necessarily too much. And Life for a Child is actually supporting a few studies, and would be open to considering supporting other studies, not with large amounts of money, but with very targeted, precise amounts of money on well-designed studies. And we've published a few studies. There's more coming through, and we'd be happy to help with more.
Okay, let's move on to Pablo. Yeah,
I would just like to comment that the most expensive study is the study that was not well done and was lost. And finally, the money wasn't well spent. So I think that the guide, as Graham already mentioned, will give the guide will help to organize a good study with a proper calculation of the sample size and with the instructions to get it to the end and be published. And that way, with not much money, it will be value for money. So I would recommend that do really try to organize a good study, and it will not be as expensive as it was thought.
Jackie, did you want to make a comment on this?
Yes, sometimes the categories decided by the World Bank on which are the low-income countries need to be re-evaluated. For instance, what happened in Lebanon, starting with civil revolution, then devaluation of the currency, terrible financial situation and economic situation, to start after that with the pandemic, which touched us all, and then ultimately to end with the unfortunate Beirut blast that I'm sure you all heard of, the third biggest explosion in the world. Lebanon is not categorized as low-income country, but given all these things, I think a helping hand should be extended to continue being one of the leading countries in research in the Middle East and exporting the best doctors to the world. Wherever I'm here now, I happen to be in the US, and so many doctors I meet are from Lebanese origin. So that also should be considered when giving funding, because preferably it goes to low-income countries, but then again, some countries are suffering without being in that category. Thank you.
Thank you, Jackie. Well, let's move from a question that I think we could talk about all night and perhaps still not get a definitive answer to a slightly more straightforward one. Suvi, there's been a straightforward one just asked about where people can access this report and the PDF. Perhaps you could just remind people how they can get that.
Yes, it is available at idf.org website, and we will send the link to everybody who have registered to this event afterwards.
Thank you. There's a question about some of the more technical aspects of it, and Pablo, perhaps you might address this in terms of what is and what isn't included in the guide. We have a question about whether the calculations of DALYs, years of life lost, etc., in different diabetes types. Is that sort of material covered in this guide?
Well, the essential about how to calculate it is included in the guide, and it also has a great number of references of practical publications which will help to do the necessary calculations. So to summarize, it's not a textbook on statistics, and so you will not find details of all the calculations, but certainly you will find very practical references on where to find more details on each issue.
Thank you. Sarah, I'm going to come to you now about a question that we have about sort of diseases associated with diabetes. And the one that's come up in this particular question is about fatty liver disease, which, like diabetes, is also a common condition with some similar risk factors and some slightly different risk factors. So the question is, how will studies be able to address this kind of issue? And I wonder whether you might start about the role of registries in sort of linking diabetes into other conditions, but we might also discuss how the standard epidemiological study might do it as well.
Certainly, yes. I have a personal interest in fatty liver disease, which is much more difficult to identify than diabetes. So I think if it's not the comorbidity of diabetes that I would start with if I were starting a population-based study, really to the hepatologists think you need a liver biopsy to diagnose fatty liver disease, and clearly that's not something we can be considering at a population level. So you'll have to watch me because I could talk about this for a long time, but I think it's not something that's easy to measure or at a population level, and certainly even in high income countries it's difficult to establish from routine data. So it's something that we're working on to try and get better measures in routine data, but I'll use that as a link to other conditions, other comorbidities. I think there are other conditions that are far more easy to identify from routine data. We've been very interested in the links between diabetes and cancer. The link there, particularly with type 2 diabetes, of course, is through obesity. Again, not every country by any means has a cancer registry, and even developed countries may not even have whole population cancer registries. The most common complication, of course, of type 2 diabetes and type 1 is cardiovascular disease, and we have enough challenges identifying cardiovascular disease as an important complication of diabetes from routine data. So I look forward to further discussions with whoever asked about fatty liver disease, finding out about their views of measuring it, but it's not the comorbidity that I would start with, I'd have to say.
Ayesha, can I just ask you to just comment a little bit more broadly on prevalence studies or cohort studies that you might set up with a view to looking at other related conditions? And you know, how important is that? Should we really just be doing a diabetes study and putting all our effort into measuring the blood glucose and the relevant direct diabetes information? Or should we be looking a little bit wider, and does it matter if we have a public health perspective or an academic perspective?
I think certainly well, actually both for type 1 and for type 2 diabetes, I think it's important that we measure other things like the association with hypertension, with dyslipidemia, the amputation. There's not too much when we're looking at not cohort studies, but certainly prevalence studies, to look at complications. Certainly from the Africa region, there's nothing that has used sort of harmonized approaches to looking at complications, simple measures like looking for microalbuminuria, or for looking for whether there's a history of amputations, and these things or blindness. There isn't. So what we basically do in these studies is just look at diabetes and impaired glucose tolerance or impaired fasting glucose, and then we're happy. But we forget that it's part of a broader picture, and I think that these should be included of necessity in such studies, and not necessarily where you have biochemical measures, because I mean, in low-income countries and middle-income countries, whatever Pablo says, undertaking studies such as this are extremely expensive, because we do not have access to all the facilities that are available in high-income countries. So it's not true that it's not expensive, because mounting a good study is actually expensive. And doing biochemistry, which is often involved with diabetes studies, is exceedingly expensive. HbA1c is very expensive in low-income countries. So we can do all of these things and perhaps analyze them as our data becomes more important.
I might just make sort of one other point about this, which I think you know, sort of links this comorbidities back to the funding. You know, if you try and get a study funded just for diabetes, you might struggle. Whereas if you take a broader NCD approach and look at obesity and hypertension and, you know, whatever are other relevant non-communicable diseases for that particular population, you probably have a higher chance of getting it funded and more sources to go to. I think the other way of thinking about it is the extent to which it needs to be an academic study, which is answering a truly novel question. And you know, if there's a component of it that can do that, rather than just what is the prevalence of diabetes in my country, which is an important public health question, but if you can combine it with something of academic interest, there may be some other avenues of funding that would allow you to conduct it in order to answer that specific question. I think Pablo had his hand up first, and then back to Aisha.
Yeah, actually in the prevalence chapter of the guide, we did discuss this and try to organize a kind of a table where we can see the importance of different measurements, both for diabetes and for cardiovascular disease. And we hope it will help to choose which lab tests are really worth doing, depending, as Aisha mentioned, on the budget. But I think you still can do medium or low budget studies if you really do it the right way and as parsimoniously as possible, as we tend to mention, use that word in epidemiology.
We're getting towards the end. I just want to fit in two more quick questions. Perhaps the first one to Sarah. What are the risk factors for type 2 diabetes that haven't been explored adequately?
Oh gosh, that's a challenge to put me on the spot. I'm particularly interested in inequalities in health and the socioeconomic differences in diabetes, and particularly for type 2 diabetes, obesity is thought to be the major driver, but the socioeconomic inequalities aren't completely explained by obesity. So I think there are opportunities there for exploring what that is. Clearly, we find it very difficult to measure diet and physical activity very precisely, and there may well be other factors in there that we can find, and it's a topic of ongoing research, certainly. And of course, risk factors for type 1 diabetes, there are still many unanswered questions there. So for anyone interested in diabetes epidemiology, there's plenty of work to keep us busy, I think.
Douglas, a quick comment from you, I think you wanted to make?
Well, there is an ecological side of diabetes, of the development of diabetes in our country, because we have in the highlands, it's very dry and no agriculture. In the lowlands, a lot of floodings, and people are moving from their local towns to big city because of this ecological climate change and the movement from rural communities to the city. We know more, but we never thought about the climate change.
Yes, I mean, I think the point you make there really is sometimes being smart and clever about the circumstances that you have might mean that you have there's a question that you can answer more easily in your setting than others can, and sometimes that also might be a way of opening up funding. I'm going to just come back for one last question to Suvi. It's really just about resources. I might take the first part of it, but we've got a question about if there is online training or guidelines for CGM, for example, and how we can use it in low-income countries, and guides and how to learn from it. Well, there are a number of resources for CGM. I'm not sure whether the IDF has any of those, but Suvi, you might comment on that, but particularly on the course for this guide, and where people who want to not only read it for themselves, but attend a course and get a little bit more in-depth knowledge from some of the authors.
Yes, indeed. We are developing currently a course based on this publication that will be placed on IDF School of Diabetes platform, and it will be available later in the second quarter of this year, so in 2-3 months' time. And we'll also inform everyone. There will be an announcement when it will be available for everyone.
Well, thank you very much, Suvi. I'd like to thank all of the panelists. We've just about got to the end of our hour. It's all sorts of times of the day and of the night, not only for the speakers, but no doubt also for many of the people tuning in. This is a very valuable resource. We have Pablo very much to thank for this in addition to a range of writers and contributors, some of whom are on this presentation this evening. You can see, I think, on Douglas's background there's a map of the world. If it was a map of where we have data for IDF, it would be a lot less complete than the one that we can see behind him. We know a lot about the geography of the world, but a lot less about some of the things that fill in that geography and the challenges that we have with diabetes. And knowing the number is often a critical element in getting funding for the care and the appropriate resources for people with diabetes. If you can't tell your government ministers, your politicians, how many people and how big the problem is and how much can be solved, you'll get swept aside when someone else does. So any way that people can to improve the data is valuable for those of us who are interested in global epidemiology, but much more valuable for those people who are at the coalface in each of their countries. We've heard about the coalface from Jackie, from Douglas, from Ayesha. These are big struggles that people face. So I'd like to thank everybody for joining, thank everybody for presenting tonight, and wish you a good morning, a good afternoon, good evening, and good night.
Thank you.
Thank you.
Thank you.
Thank you. Goodbye, everyone.
Thank you.